Thanks for joining Shae's Ask the Stewie series. This series is made possible from expert members from the Shae Antimicrobial Stewardship Committee answering questions submitted by our membership. This month, we're joined by Dr. Kristy Shaeer and Donald Drumford. They are going to be answering a question that comes up regularly. How does one have an appropriate conversation with the medical staff about placing residents on antibiotics for asymptomatic bacteria, especially in long-term care residents who always have a resistant organism each time a urine culture is set? Dr. Shaeer, do you want to get us started?
Okay, thank you, Kristy. All right, I think first I would like to pose a question to my colleague and find out why exactly they're ordering urinalyses and also cultures in these patients, and find out if these labs are bundled with other orders that they're trying to get, and really try to find out why they're ordering it because of the fact that they're not symptomatic at all. And also talking to them about how this particular patient population, it's quite common to have asymptomatic bacteria in long-term care residents, and then also in populations oftentimes in these facilities are age 65 and older, and trying to discuss the rationale behind the order, and trying to see if there's any way to unbundle that. And oftentimes when you get these results back and they're positive, then providers are inclined to want to treat it. And really, if there's not focal infections, focal signs and symptoms, then there's definitely harm associated with treating, putting the patient at risk for adverse effects. And Dr. Drumford, would you like to add to that?
Yeah, thanks, Dr. Shaeer. I think all your points are extremely great. And that was a great idea to start the question off with, why are you ordering this urinalysis? We've been trying to hammer home at our institution that you should really only be ordering urine cultures if you're going to believe the results. And I think you brought up the good point that as soon as you've got that result in front of you, there's going to be a definite proclivity to treat it, even if we're in that episode of asymptomatic bacteriuria. And I usually, as we're starting to start the conversation, kind of go back to the literature and then take it to their patient about what the what the risks are and what the benefits are. So I'm really just point to the fact that when we've looked at asymptomatic bacteriuria, when people are undergo placebo-controlled trials, that there's no benefit to the antibiotics, that the patients that get antibiotics are just as likely that those that get the placebo to go on to develop a symptomatic urinary tract infection. And as the question pointed out, is that we're dealing with a population that is going to be at risk for multi-drug resistant organisms already. There's also a population that's going to have a much larger chance of having C. diff. So if you're putting them at risk for C. diff, that's one thing. And then also just thinking about that antimicrobial resistant, we really got to choose our battles in these patients. So if you're given an antibiotic for what might be a susceptible Pseudomonas, and you give Piptasa or Cefepime, when you actually need it a week later when they've really got a symptomatic urinary tract infection, they're septic, you might be left giving them a toxic medication like an immunoglycoside. I don't know if you've got any other thoughts, Dr. Shaeer, on that.
I think you nicely summarized it. We also, this is definitely something that takes a lot of education, and we really have to be judicious about when we need to order it. And it does get a little complicated, of course, when you have this it's complicated patient populations that often reside in these facilities, and assessing true versus not infections. But with this patient not having any symptoms at all, definitely want to be judicious about not treating them, because like you said, we're going to keep running into that case where these organisms are going to keep showing up, and then if you're going to keep treating them, then you're going to cause more resistance, and then start to wonder what are we going to be able to use next in this patient. And there's really only limited reasons why we would need to treat asymptomatic bacteria, and this definitely is not a situation where we would want to do that.
Mm-hmm. I think probably just to remind everybody what those, what those scenarios are where you actually should treat as asymptomatic bacteriuria. It's really limited to just probably in the patient we're talking about with nursing homes is, prior to urologic procedures, or in probably not the nursing home population in pregnancy. And really those are really the only times with asymptomatic bacteria that you really have to be giving antibiotics.
Absolutely.
So, and I think too, we should probably just think about the fact that I think antimicrobial stewardship and fighting antimicrobial resistance is really all of our jobs right now, not just us stewards, but even that frontline staff with the nursing homes.
Absolutely. Yeah, definitely an area that needs to be partnered with. So definitely.